1919. And we still largely really depend on this classification, much as of recently some bit of controversy, but by and large, we are still depending on Young's classification, which classifies these posterior urethral valves into three classes, and we shall see them later. Now, posterior urethral valves occur in 8,000 to 25,000 live birth, and the classic posterior urethral valves occur only in males. Valves have also occurred in siblings, twins, and well, the genetic component or the inheritance, there's not really substantive data to show that there is inherited, but there are some siblings and twins that have showed posterior urethral valves. And this last bullet is very important, that despite optimal treatment, posterior urethral valves in children may result in renal insufficiency in nearly 1/3 of cases. So even when you manage these patients, later on they usually develop renal insufficiency, and about maybe 50% of these patients will end up with end-stage renal disease. So even when you manage it in time very well, you should always counsel the parents that later in life, these children may actually have renal insufficiency, and therefore the importance to monitor their renal function. Now, we had already talked about the classification and the embryology. We said there are three types of valves, and type number 1 is the commonest. It's in about 95% of cases, and in this one, there are two membranes that originate at the distal aspect of the verumontanum, and then they fan out and attach to the urethra to fuse in the midline anterior, just proximal to the external sphincter, external urethral sphincter. It's important for you to have this anatomy. So before you start the prostatic urethra, there's something on which the ejaculated duct drains, and distal to it, you usually find the sphincter. So the type number 1 comes from the veru, and they go anterior, or you can even consider it to be distally, and they fuse. They may fuse, and they attach just proximal to the external sphincter, and therefore during their treatment, if you are not very precise, you can easily injure the external sphincter. In majority of these cases, the fusion of these valves anterior is not complete, and therefore they leave a gap where someone can pass some urine. Of course, this arrangement means that if someone is trying to urinate, the urine may not pass, but the catheter is likely to pass. So in these patients, we shall see later that you can actually pass the catheter because of the arrangement of the orientation of these valves. As we've said, the type number 1 is the commonest. It will be found in 95% of all posterior urethral valve cases. So the embryology of posterior urethral valves is speculative, and it is thought that it may be related to an abnormal insertion of the mesonephric ducts into the fetal cloaca. The thickness of the valves varies. They could be rigid, they could be thick tissue. Sometimes it's just very thin. Even sometimes it is so transparent. Of course, the thinner, the better for you, the easier for you while you operate this patient. Type 2 is sort of no longer considered to be a type of posterior urethral valves because they are not obstructive, and they probably result from hypertrophy of the muscles of the superficial trigon and the prostatic urethra in response to the high voiding pressures from the distal obstruction. So these sometimes are not considered as a true type because it doesn't cause any obstruction, and that's the orientation. So remember, type 1, the valves were starting from the veru and going anterior or distal. In type 2, they start from the veru and go proximal or superior. So that's the difference. And the type 2, they don't cause obstruction. Type 1 causes serious obstruction. Then there's type 3. And this is a membrane lying transversely across the urethra. It is usually distal to the verumontanum, and it has a small perforation in the center. And the embryology of these has been attributed to incomplete dissolution of the urogenital membrane. Type 3 makes up about 5%, and they usually actually cause more obstruction because in this case, the whole circumference of the urethra is involved, leaving just a small hole in the middle. We shall have a picture that will help us understand this. Let me pick my pointer. So this is type number 1. We said it starts from the veru. This is the verumontanum. This dot here, that one. In all the pictures, that dot is the verumontanum. Okay. So we are seeing that type 1 they come from the verumontanum and they slope. Okay. So they attach distal to the verumontanum. Okay. And we said the fusion is not complete, so it leaves some small space. Okay. There you go. And here they've removed the urethra, and this is what is obstructed. Okay. The type 2, they come from the veru and go up like that. See, the veru is here, they are going upwards, and that's the orientation of type 2. Type 3, we said the whole circumference, and they leave a small hole, and that white point is the hole. All this is the valves, and you can even see it in this picture with a small hole in the middle, and the rest is a valve. When the baby gets these valves, because remember it starts in utero. So what is the pathophysiology? In other words, how do these posterior urethral valves affect the different areas of the urinary tract? So in this pathophysiology, we shall realize that the bladder, the urinary bladder suffers, the posterior urethra suffers, and of course, the ureters and the kidneys, because those are all proximal to the point of obstruction. And of course, the worst is pulmonary hypoplasia. And this is the commonest cause of serious problems in these children. So the valvular obstruction develops at approximately 7 weeks of gestation. And if there is early outflow obstruction, this one, of course, will lead to abnormality in the bladder wall components, and it will also lead to renal dysplasia. Renal dysplasia is irreversible, and we shall see that is the difference between it and the obstructive uropathy. That for the obstructive uropathy, if you relieve the obstruction by working on the patient, then it may resolve, but renal dysplasia doesn't. So renal dysplasia. happens more commonly. Please mute. So if there is early outflow obstruction, then the patient is likely to have renal dysplasia. If the obstruction is later, then it results in the typical sequelae of chronic bladder outlet obstruction without the occurrence of renal dysplasia. So in the bladder, what happens to the bladder if there are posterior urethral valves? And there is a thickened bladder wall due to hypertrophy and hypoplasia of the detrusor muscle with increased connective tissue. And we know that if that happens, then the compliance of the bladder is distorted, okay? The compliance means that ability of the bladder to accept urine until a significant volume when someone feels like urinating. And if there's hypertrophy of the detrusor muscle, of course, even the contractility of the bladder may be distorted. And therefore, we shall see later that these patients may actually have problems passing urine, even when you have eliminated the obstruction, because the detrusor muscle and the connective tissue have been changed from the normal. You have a distended bladder, of course, because of the obstruction at the prostatic level. Then you also have a bladder neck that is rigid, hypertrophied, and also elevated. And this may be difficult to catheterize. And all this is because there's obstruction. There's obstruction from the posterior urethral valves. Of course, sometimes you can have diverticuli. And we shall see that these are some of the mechanisms the urinary system may use to reduce on the pressure. So sometimes, because of the obstruction, you may find bladder diverticuli. So in the bladder, we already said there will be poor compliance, poor contractility. There's high pressure urine storage and voiding, and of course, the valve bladders will seldom, if ever, achieve normal function. And that's what I was trying to explain earlier, that because of these changes, even after you have operated the patient and the valves have been worked on, they find it very, very difficult to achieve the normal function. They may improve, but later in life, they usually will show that the blood actually did not attain full function, and they start getting problems that are in relation to poor compliance, hypercontractility, and high pressure urine storage and voiding. Now, in the prostatic urethra, what happens? Because these valves, we said, are just around the, just at the end of the prostatic urethra, we expect that the obstruction will have very serious effects on the prostatic urethra. And the prostatic urethra will be distended and thin. And the vero may be also distorted with the ejaculatory duct being dilated. We already said on top of the verumontanum, that's where the ejaculatory duct empties. And this duct may be actually dilated because of reflux of urine. So in the ureters, virtually all valve patients will have hydroureteronephrosis, and the ureteral wall will be thickened, and the lumen, of course, massively dilated. And hydroureteronephrosis can be the result of vesicoureteric reflux or due to the obstruction of the valve from the valves, or both. Now, in the kidneys, renal injury in posterior urethral valves has two distinct causes. And we already said that One of the effects on the kidneys can be from the obstructive uropathy, and the other can be renal dysplasia. Please advise your colleagues to mute because they are causing, they are interrupting us.
Doctor, you can proceed. I've muted them.
So the effects on the kidney can either be due to obstructive uropathy, or they can be due to renal dysplasia. Obstructive uropathy is potentially reversible with the relief of the high pressures, while renal dysplasia is not reversible, like we had already said. The extent of the dysplasia will ultimately determine the growth and functional potential of the infant's kidneys. So obstructive uropathy involves both the glomerular injury and the tubular injury. And the glomerular injury occurs when the high pressures result in decreased renal perfusion and filtration, while tubular damage results in failure to concentrate and acidify the urine. And of course, failure to concentrate the urine will lead to diabetes insipidus. And these large urine outputs stress the ureters and the bladder and contribute to the persistent hydroureteral nephrosis, because worsens with age despite the early relief of. And to note is that infections, persistent obstruction, hypertension, hyperfiltration of damaged parenchyma, and perhaps the high protein diet may contribute to the declining renal function. And so some of these should be either monitored for or even treated. You'll meet something like Popov mechanisms. It's just for you to really appreciate. So these mechanisms are mechanisms that the urinary tract uses to lessen the effects of the high pressures. Remember, this problem starts when the fetus is unborn, and so for the kidneys to survive, there are some mechanisms that they try to employ, and those are the ones we are calling the Popov mechanisms, including the diverticuli we talked about in the bladder. Okay, and it is not very rare for you to find that there is unilateral reflux when you do the images. You find that the obstruction ideally would cause hydronephrosis on both sides due to reflux, but the kidneys decide and only one side has reflux and hydronephrosis, and the other one remains normal. And the other pop-off mechanisms include the bladder diverticuli, like we had said, the urinomas, and the urinary ascites. So the other problems in posterior urethral valves include pulmonary hypoplasia, which results from oligohydramnios, and the exact etiology of the pulmonary hypoplasia is still unclear, but the contributing factors may be physical restriction of the fetal breathing motions. Remember that when you have, when the urinary tract is not obstructed, then you have adequate amounts of amniotic fluid. And those adequate amounts of amniotic fluid help to cushion the baby. They give the baby chance to breathe very well and to be cushioned against pressure effects. And so when you have obstruction, that's how you end up with oligohydramnios. That's the connection. I hope that is clear. And the amniotic fluid surrounding the fetus, surrounds the fetus and buffers it from intra-abdominal pressures and may provide the intraluminal pressure, the volume, and the flow needed in development of the fetal pulmonary tree. So the cause is unclear, but it's thought to come from the oligohydramnios. And like we had said earlier on, pulmonary hypoplasia is the worst, like the most severe problems these children will have. So that is it about the pathophysiology, and I hope we have understood so far which effects posterior urethral valves have on the different aspects in the prostatic urethra, in the bladder, in the ureters, in the kidneys. And with that, I think we can now discuss the clinical presentation. The clinical presentation also is dependent on the timing of the diagnosis. And we know now that we can actually do antenatal diagnosis of posterior urethral valves, but also posterior urethral valves can also present late, that the children may be considered to have failed to stop to achieve continence of urine until they actually come. So there are sometimes when they come late also. So there's late presentation, there's antenatal, there's a newborn. You can also diagnose them in the neonatal phase. So we shall see all that. Yes, so this is what we are talking about, that you can do a prenatal presentation, there is neonatal, there are older children, and there are aspects of bladder dysfunction and the valve bladder syndrome. We shall look at this. So in utero or the prenatal, posterior urethral valves are suspected on a prenatal screening ultrasonography. And that scan will show the following, which should raise your suspicion or confirm your posterior urethral valves in the prenatal phase. So among these features is marked hydroureteronephrosis, a thickened bladder wall, a distended bladder, oligohydramnios, intrauterine growth retardation, and what we call the keyhole sign of a dilated bladder and posterior urethra may be seen. So these are the features, and if they are done, if the woman has ultrasonography, these features may be used to confirm the diagnosis of posterior urethral valves in utero. So this diagram is showing you the bladder. Let me just pick my pointer. So it's showing you the bladder. Okay, this is the bladder, and you can see the bladder is distended. The wall of the bladder is thickened, and this is the prostatic urethra. Okay, and what we were calling the keyhole sign is all this. Of course, you guys now are used to these, the newer keys, but if you could just imagine the older keys of your parents or grandparents, this is where the name comes from, keyhole. That's how it used to be. Okay, you can imagine there are some keys for those long time ago, and this was the keyhole, really, where the key would enter. That was its shape. So this is the bladder, this is the bladder, and this is the prostatic urethra that is dilated. So in the neonatal presentation, pulmonary hypoplasia is the most severe clinical problem facing the neonates with posterior urethral valves, renal insufficiency manifesting as a failure to thrive. Lethargy or poor feeding may also be a presentation. And of course, skeletal abnormalities from intrauterine pressure. Remember, we said that amniotic fluid is supposed to cushion the baby. It doesn't allow the baby to really get pressure effects. But if there is oligohydramnios, then you'll have pressure effects, and they are more common on the limbs. Okay, so you may find deformed limbs with the pressure dimples over maybe the knees or the elbows, because those are the most affected part fluid. Now, palpation of the abdomen may reveal masses due to hydrourethral nephrosis and a distended bladder. And there may be urinary tract infections or urosepsis, urinary ascites, and the infants may actually also have extensive edema. Now, in the older children, boys who present later in life are generally believed to have normal urinary tract. They may present with urinary tract infections that are recurrent. They may have voiding dysfunctions. They may fail, in other words, they may fail to actually empty their bladders. And of course, they may have the valve bladder syndrome, which we may also have a look at later. So bladder dysfunction, in these infants, the bladder is thick and trabeculated with circles and diverticuli. It is hypercontractile and the compliance is low. In other words, these are patients who will have frequent urination. The bladder does not comply, it does not accept the normal volumes of urine before you have a feeding to void. And late in childhood, the bladder is less contractile, but displays poor compliance. Okay, so initially it is hypercontractile and the compliance is low. Later in childhood, the bladder is less contractile, and therefore you know that you need the bladder to contract normal for you to void. So these patients will fail to void, and some of them will even require intermittent catheterization, self-catheterization. Both the hypercontractile bladder of infants and the rigid bladder in the late childhood inhibit the upper urinary tract drainage, and therefore these patients, whether they have hypercontractile bladders or rigid bladders, they'll always have hydronephrosis and hydroureters. So 3 urodynamic patterns are seen in valve boys. That is myogenic failure. In other words, failure of the detrusor muscle to contract. You have detrusor hyperreflexia, and then you have decreased compliance, or a bladder that has a very small capacity. Please mute this person. Myogenic failure usually occurs in older children, and it leads to overflow incontinence and incomplete bladder emptying. Detrusor hyperreflexia leads to urinary frequency and urge incontinence. So incontinence is the major problem of valve patients and is thought to be due to a combination of poor bladder sensation, poor bladder compliance, and also detrusor instability and polyuria. The combination of the poor sensation, the high bladder volumes, and the poor compliance produces storage pressures high enough to prevent the adequate drainage of the upper urinary tract, that is the kidneys and the ureters. And this results in the valve bladder syndrome. So in the diagnostic workup, I think it is important to know if you found bilateral hydronephrosis, what the differentials would be. And we have posterior urethral valves is one of them. Pulmonary syndrome, you may have a bilateral uretero-pelvic junction obstruction. You may have bilateral uretero-vesical junction obstruction. You may also have bilateral high-grade vesico-urethral reflux. Of course, you may have congenital urethral atresia, or you may also have anterior urethral obstruction, maybe from congenital anterior urethral valves. These are we're talking about the posterior, but they are also anterior urethral valves. It may also be due to congenital strictures that are very rare. So when you're working up the patient, this is what you're thinking about. And you want to end up making your diagnosis of the posterior urethral valves. In the workup and in the ultrasound scan, the classic ultrasound scan findings in these patients will include bilateral hydroureteral nephrosis. In other words, both the kidneys and the ureters will be filled with urine. A distended bladder, you may have a dilated posterior urethra, what we call the keyhole sign. You remember we have gone through it, and we said it is due to the dilated bladder above and the dilated prostatic urethra. The bladder wall will be thickened. We also appreciated that. And of course, there will be renal echogenicity that is increased. And of course, there will be also decreased amniotic fluid if the ultrasound scan is done in the antenatal phase. Avoiding cystourethrogram is the most important study in diagnosing posterior urethral valves. So in other words, if you get a child who is straining to pass urine or has overflow incontinence, is dribbling all the time, then we should be thinking about posterior urethral valves. And if you're thinking about posterior urethral valves, we are saying that avoiding cystourethrogram is the most important for the diagnosis. The proximal urethra is quite dilated, and the actual valve structures are often visible in these images. You can also appreciate bladder diverticuli. You can appreciate severe vesico-ureteral reflux, and there's an 80% incidence of reflux on the left side. The left is more affected. There's no particular reason for this, but the left seems to be more affected. And in the lateral projection, the bladder neck, like we had said earlier on, will usually be found to be elevated. So this diagram, let me just pick my point. So this diagram just shows you, of course, it's not a complete one, but you can see it's just meant to show you that this is the bladder. You can see the bladder neck is narrow also, and is also showing the prostatic urethra. You can see that this is the prostatic urethra, and the point of obstruction is just there. So this is the bladder up there. This is the bladder neck, and then there's that distended prostatic urethra. And then this other picture shows you, ideally, this urethra would be open, like you'd be seeing it open, but the only open point is there. Okay, maybe up there. So this is also a picture to show you the posterior urethral valves when you do a urethrocystoscopy. So this is an endoscopic image. This is another picture also showing you some of the reflux. This picture shows you a very irregular bladder. Okay, see that irregularity. But also more importantly, you see this is the hydroureter, okay, and hydronephrosis. These are the calyces, okay. And we agreed that you read about the imaging modalities, and when you read about the IVP, they will tell you that these are described as clubbing, okay, or blunt. So every time you see blunt calyces, you know there's obstruction, and you can see that there's severe distension of the pelvis, the calyces, and the ureter down there. And this is bilateral because even this side, you can see it. And the pop-up mechanism we're talking about is that sometimes you find severe hydronephrosis on one side and the other side is normal. And it is a method that reserves one kidney while absorbing the high pressures only on one side. Of course, this one also shows a very huge bladder, and you can see that there's some point of narrowing there, and this is probably where the urethral the posterior urethral valves are. And of course, you can see that there is distension of the prostatic urethra. So again, the radionuclide renography or the renal scans are very important because these ones differentiate, they provide differential renal function, and they also give some insight about drainage of the upper urinary tract. And in particular, mercaptoacetyl triglycerin is a more useful agent for this study. Yeah, these studies are able to tell you that the right kidney contributes this percentage to the function. The left kidney contributes this percentage, so that you know whether you should actually, for example, make effort to save one kidney. And it is said that if a kidney is giving you less than 10%, then that kidney really doesn't contribute much, and it shouldn't be salvaged. It's beyond. It's already, the effects on it are already massive. Some literature will consider 15. So basically 10, 15%. If any kidney provides less than that, then you may not need to salvage it. So these renal scans are very important in giving you the differential function. In the lab workup, you want a creatinine, you want burn, and you also want to know the electrolytes of these patients. We already said that they may have issues concentrating their urine, acidifying their urine, and so you should have measurements of the serum bicarbonate, sodium, potassium, and these are all critical in monitoring the prognosis of these patients. So in the management of these patients, we shall look at specific aspects and just really mention about some others, which I may think you may not need to really struggle with. So in the management, what is important, I will focus more on the bladder drainage and the definitive treatment of posterior urethral valves. But you should know that these patients may have problems of vesicoureteric reflux, which may need to be addressed. And these days we commonly do reimplantation, but of course there are conditions before you do that, especially for the bladder capacity. If the bladder capacity is normal, then you can do you can treat the vesicoureteric reflux by doing the reimplantation of the ureters, and you use an anti-reflux technique, which I don't think for your level we should go into, but you should know that the reflux has a solution. The hydronephrosis will reduce, sometimes we even resolve when you relieve the obstruction. The bladder function, we already said that sometimes the bladder will be hyperactive, okay? And sometimes the bladder will be, will have poor contractility. And therefore, depending on what the problem in the bladder is, you may want to treat accordingly. For bladders that are hyperactive, you may actually give anticholinergics, and they may help. For those bladders that have issues with contracting, then you may actually have to advise the patient to to do timed micturition, or even an intermittent clean self-catheterization may be an option. Of course, the antenatal management, because we said you can monitor, you can diagnose these patients before they are born, and you'll meet things like vesical amniotic shunts, which I don't think I should go into, but basically you are shunting the urine from the bladder to the amniotic fluid. And of course, like we said, a big number, about 50% of patients with posterior urethral valves, even when managed adequately, they will end up with renal insufficiency and end-stage renal disease. And therefore, some of these patients will require kidney transplants later in life. And so that's really roughly how these other issues can be managed. But for you, I want to focus more on the bladder drainage. And the bladder drainage is accomplished by the following methods. You can put a urethral catheter, and we said the commonest type of the valves is the type 1, and we said because of its orientation, it is easier actually for you to catheterize because you are going retrograde, and the way the valves are oriented, the catheter will have no problem. Of course, apart from the high bladder neck, which may give you issues. So catheterization will be possible, and this should not confuse you. And many parents, when they bring their children, say, but if the way is blocked, how come the catheter is able to pass? It is because of the orientation of these valves. So urethral catheterization is possible, okay? But when the urine is flowing antegrade from the bladder, then the valves collapse on themselves and cause serious obstruction. So the catheterization is possible, but there are also some of the children who are very young, and you may not want to start poking things in their small urethra, and a cutaneous vesicostomy is used, especially for neonates. And this is just used to buy time for you to do the valve ablation or valve incision. Valve ablation and incision are the definitive treatment, definitive surgery for this condition. But these are endoscopic surgeries, and I don't know whether you guys have seen some endoscopic surgery, but it involves passing some equipment via the urethra. And some of these children will have a small urethra, unable to accommodate the equipment. So what you want to do is to first give them a cutaneous vesicostomy. I'm sure you know an ileostomy. So you can use that to understand when we say a cutaneous vesicostomy. We are just doing a stoma of the using the urinary bladder, and we're just putting it out there so that the urine just drains by itself. And this is done just to buy time as the child grows, for you to be able to do the ablation. When the penis is bigger, the urethra is adequate, and the equipment you have can actually pass very comfortably for you to do the definitive treatment. So neonates can be catheterized with the pediatric feeding tube, but like we said, a vesicostomy can be performed if the infant is too small for the instruments to pass, for you to do primary valve ablation. And of course, Foley's catheter are used, but it may be difficult to pass it over an elevated bladder neck. So we've said the definitive treatment is valve ablation and incision. These are two methods that you can choose, and we are currently at the hospital able to do ablation, or what we call fulguration, and we shall see. Maybe you will have a chance when this COVID time has relaxed and we've got our vaccinations and we go back to full operations. So the most important thing is to know that the definitive treatment involves either ablation or incision of these valves. So this diagram just shows you, let me just pick my, this diagram shows you a posterior urethral valve, okay? And it shows you in this picture, it shows you, this is called the Bagby electrode, okay? The Bagby electrode supposed to be burning the valves, ablation or fulguration. And you can see that here after burning, this is the same patient. Here is the patient, and after burning, you can see all this now is open, okay? So that is how we do fulguration. For the incisions, you make the incisions at 4 and at 8 o'clock. Some people go at 12 o'clock also, but that's how you. So for the incisions, you just make incisions from there to there, from there to there, and also at 12 o'clock. So that the valve mechanism that was closing off the urine in the antegrade direction is now no more. Now you create free flaps which can go either side, so the urine can also pass. So those are the two methods. You can either do ablation or you can do incision. So the take-home message is that these posterior urethral valves happen only in males, and they are not very common, but you should look out for them. And it accounts for 20% of all childhood end-stage renal disease. And we also already said that of all the patients with posterior urethral valves, about 50% will actually end up with end-stage renal disease. Of course, we've also said that renal dysplasia is very dangerous because it is irreversible, and it happens when the obstruction happens much earlier in the fetal life. Of course, you have a dilated urinary tract, and also importantly to note is that even with the best, even if you do the optimum management, these patients will usually have persistent malfunction of the bladder. So this is what is important, and of course to add that the most important investigation, the gold standard, is avoiding cystourethrogram for these children. Now with that, we've come to the end of our presentation, and maswali is questions. For those of you who don't know Swahili, it just calls for questions. So we are going to be using our usual methods that we actually either put up our hands and
Hello, doctor. Doctor has dropped off.
um, This is very good questions. Thank you for this question. And you remember that we said there are two options when we manage these patients. And one is ablation and the other one is incision. And several researchers have shown that incision is better. Okay, incision is superior to ablation. So, and that superiority is also in terms of recurrence, relieving symptoms. So of those two types, if you can do incision, it is better. But incision comes with more costs in terms of equipment. The ablation, as long as you have what we call a bag B electrode, you can always do a good job. And of course, the other factor you should consider is that we said so. We're saying that of course the other problem is how thick. So what we are saying that the other problem is how thick the valves are. If you have membranous valves, you are more likely to have good outcomes if you compared to if you find very thick valves. So there are many things to consider, but at the end of the day, we know that incision is superior to ablation. Then this is Joseph Mwonge. Doctor, can you please throw more light on high pressure urine storage? The meaning. So remember we said the posterior urethral valves, they cause obstruction, and we said the bladder, the detrusor is not as compliant as it should be. Compliance means the bladder is able to relax as urine enters the bladder. The bladder will relax until the normal volume, 300 to 500, until that normal volume that is supposed to give you the urge to urinate. But because of the poor compliance, the thickening of the bladder, the poor compliance, even little urine, even just 100 mils of urine, because of the poor compliance, the bladder will actually seem as if it is already full. It's not able to relax. And therefore, those storage, that urine storage in such a bladder will definitely be at a high pressure, okay? Because the bladder is not compliant. It's not accepting to take the volume. Even small volumes will be at very high pressure. Then, doctor, how long does end-stage renal disease take to set in, and how much is the procedure of valvular ablation and incision? Dr. Elias, Elias, thank you for your question. I see you're already thinking in terms of money, but I will tactfully dodge this question. Medicine is not for making money; it's for helping patients. So we should be thinking more of how we help. We are actually able to do ablation at the hospital. How long it takes, there's no definite time, but what is clear is that you need to keep monitoring the renal function of these patients. Doctor, how big are the equipment used in a vesical amniotic shunt, and what's the minimum age of the fetus on which the surgery is done? So the shunts, the size, how big, No, they are not big because the intention is just for you to put a tube that is able to drain the urine from the bladder to the amniotic fluid. And I think there is, if you go to that book I gave you, the pediatric book, you should check. Maybe there may be some images that will give you a picture. For you to diagnose posterior urethral valves intrauterine, the fetus must be 24 weeks and above. And so any age below that, you will not be able to pick posterior urethral valves on ultrasonography. And when you pick them, I think at any age, in those people who have the techniques, they can have the vesical amniotic shunts done. So I see the questions, I think, in the chat box are over. I will take maybe two hands.
Yes. There were 2 hands. I don't know. Alex has put down his hand. I don't know whether his question has been answered.
Yeah,
Still
my
1
question
hand.
has been answered.
He probably got answered along the way.
Joseph
Yes.
Monge.
Yes, thank you, doctor.
Okay,
I wanted to.
That's very good.
I request you to please throw some light about high pressure urine storage. Like, what does it really mean?
I think I already addressed that. We shall have another question. But do we have any other hand up?
No, we don't have any other hand up.
So we went through the high pressures. They are just about compliance, really. So we don't have any other hand. Okay. So with that,
Doctor,
I would like to thank you guys. Yes, please.
how long do you have to wait to do? You said until the penis becomes that big. So for how long do you have to wait for that child? Like maybe if he's a newborn, then
I think
how
the
is it
network is
after
bad. I
6
didn't
months?
get your question. Pardon?
How long do you have to wait before we do definitive treatment of ablation
Come
or
again,
incision?
please.
How long do you have to wait to do a valve ablation or incision in a newborn? You said that we have to wait for the penile urethra to become big. So is it after like 6 months, a year?
Okay, I didn't get that one, but I'll assume that he's asking how long you wait before you do the the ablation or the incision. And
Yes.
yes. Can you please repeat that question for me? The last question.
Yes, I can. Okay, I was asking how long do you have to wait to do a valve ablation or incision in a newborn? Is it 6 months, a year, 2 years? Because you said you have to allow the
But are
penile
you
urethra to
online?
become big. Yes, I'm online. I think I'll type the question in the urology group.